Good morning, everybody. Today's surgical resident lecture. We have our topic on postoperative bile leaks, which will be presented by Leandre Vincent. He studied in Heidelberg and joined us just recently at the beginning of January to our group, and we're happy to hear his talk. Please go ahead.
Okay, thank you for the kind introduction. I'm also happy to speak in front of you. My name is Vincent Landry, and today is the topic postoperative bile leaks, which is like a serious complications after several operations. These are the operations that's happening the most afterwards. So first of all, it's cholecystectomy, and the second is hepatic resection. We will talk about risk factors, tips and tricks to avoid bile leaks, classification, diagnostics, and in the end, the therapy. In order to emphasize the seriousness of this complication, we will talk about patient D. It's a 46-year-old woman who had a gastric bypass due to obesity 2006. In the year 2019, she developed abdominal pain and had a diagnostic laparoscopy and cholecystectomy ex domo. What happened? You can see here in the picture, she got a resection of the right hepatic arteria, and also there's an injury of the bile duct. And she was referred to us, the Center of Biliary Surgery, and she had an exploratory laparoscopy with reconstruction of the ductus choledocus injury and the hepatic dextra arteria, and was introduced several open biliary drains. What happened then? She had a hepaticouniostomy after multiple dislocations of these open biliary drains. This didn't work either. She had multiple abscessi in the liver and was listed for a transplant. Then she got a transplant on the 11th of April 2020. So what you can see here is a patient who had like a simple diagnostic laparoscopy. I'm saying simple because you don't expect this to result into a liver transplant, which is unfortunate and can happen several times. So let's talk about bile leaks after cholecystectomy. It is a complication which doesn't happen often. It's 0.2% after laparoscopic cholecystectomy. But due to the fact that this operation is one of the most common operations in surgery, in America you have like 700,000 operations, these kinds every year. We have quite a bit of this. And there's no official clinical practice guideline proposed by surgical societies for that. So the question is, why does it occur? It's been a bit ago, but in Switzerland, there were like 60% of the bile duct injuries are caused by surgeons with limited experience, like surgeons who had lower or less than 50 laparoscopic cholecystectomies. But 1/3 of the bile duct injuries were done or happened with experienced surgeons. So lack of experience is not the only risk factor we have here. So I have a question for the residents. Why do you think experienced surgeons can also have this iatrogenic bile duct injury?
Probably because they mistake the bile duct for the cystic duct.
Yeah, that's correct. So there's still a misidentification. So the common duct is mistaken for cystic duct or second cystic duct or accessorious cystic duct. There are several variations in the norm which can appear on patients, and this might result in a misidentification. I will later talk about why this can still happen. Here you can see several anatomic variations and how it was clipped. So let's see the patient-related operative risk factors. So first of all, if we have an acute cholecystitis, it's 3 times higher the risk to clip the wrong duct. Also chronic inflammation, operative bleeding obscuring the field, then fat in the portal arteria, and in the end, terminal injuries. How are these patients presenting themselves? It's not a very direct diagnostic because sometimes they have bile fluid in the drains. This happens only if we introduce the drain to the patient. Then we can have non-specific set of symptoms like life-threatening symptoms of peritonitis, sepsis, cholangitis, or external biliary fistula. And these symptoms appear 2 to 10 days post-cholecystectomy, and we can have like fever, abdominal pain, bilious ascites with or without jaundice. What we do, we will first of all, we can do a serum lab profile. Bilirubin can either be normal or high. Then we can do a transdominal ultrasound. After that, a CT. And in the end, if everything doesn't work, we can do an ESCP or an MRCP. So where's the bile leak situated? It's usually at the cystic duct remnant, bile ducts of Luschka, or main bile ducts. But the most common site is actually the cystic duct stump, which can result of faulty clip applications, slipping of the clips, necrosis of the cystic stump ducts, or proximal of the clip. Let's talk about the diagnostic a bit further. So MRCP is non-invasive diagnostic investigation, and which is very good for showing us the biliary anatomy. What we can do is the ESCP also. It's very good because we can introduce stents, so it's also a therapeutic application and not only a diagnostic one. And also PTCD is possible to show the anatomy of the biliary tree proximal to the injury and the drainage to decompress or control the bile leak. So 1994 there was a classification introduced which is called the Strasbeck classification. It's a good classification because on this we can discuss the management later on. So first of all we have type A, which you can see in the picture here. There's no adequately secure closure of the cystic duct, or it's an injury of a small bile duct in the liver bed over here. Then we have several symptoms that can appear. Type B, occlusion of an aberrant right or left hepatic duct, or it's the occlusion of the right hepatic duct. Type C and D is the injury of the right hepatic duct, type C, or a partial transection of the major bile duct, type D. These are all non-complex injuries, and we also have complex injuries, which are resulting of circumferential injuries of major bile ducts or by stenosis, and we will have an occlusion of the transection. So what is also a major problem in these injuries is concomitant arterial injuries, which might happen in 0.1 to 1.9% of the cases. And the source is usually the liver, arterial sources, or port insertion sites. Also, what can be done? It can be done like a conversion to open of the surgery to control the profuse hemorrhage, or we can have like control the cystic arteria with several clips. So one important thing is in the management, so we should avoid the explication of the bile leak because it might make matters worse, and also an adequate drainage, and then refer to a specialized unit. We will talk about later when to refer to a specialized unit like the USZ is one. So you talk about management concerning the types. So if you have type A and D, we do a ESCP with sphincterectomy and a stent placement. Also, we can do an ultrasound or CT scan guided drain, surgical lavage, and if the ESCP fails, we can do a percutaneous transhepatic cholangiography. And also, what we can do with type B, we can also do a drain, hepaticojejunostomy, liver resection, and a liver transplant, as we could see in our case report in the beginning of the seminar. So here in Zürich, when we do hepaticojejunostomy, we use a special technique. It's called the Hep-Quinault technique. So the left hepatic bile duct is inside, like this incision here, to make the diameter a bit bigger. So as I could understand it, it might prevent certain obstructions in the anastomosis later on. So what are the tips and tricks to avoid common bile duct injury? This is maybe important for the residents. So we try to make like a critical view of safety to show us a Carlot's triangle. Then it's made of the cystic duct, the cystic arteria, and the interface with the liver. And if we have difficulty with identification of the critical view, we should consider performing a cholangiography or conversion to a laparotomy. Cholangiography is not always done because there's no evidence that this is actually helping in most of the cases to prevent bile leaks. So what is the conclusion here? Adequate drainage and early referral is important to prevent further complications in the patient. The gold standard here is the hepaticojejunostomy. And also, diagnostic should be done proper for the Strasberg classification in order to get the right management, as we just discussed. So the second big reason for postoperative bile leaks is a hepatic resection. This is like after 0.4% of these operations, and the risk factors are liver fibrosis, repeat hepatectomy, veg resections, and left trisectomy. So here, where's fluid coming from? Bile leak is coming from the surface connected to the biliary tree. In this case, we should resect the leak. And then it can also be coming from extruded bile ducts, basically. So there's a classification. There's grade A. So bile leak it's basically causing no change in the patient's clinical management. B, there's an active therapeutic intervention necessary. And type C, there's we have the bile leakage and we need a relaparotomy. So what is the therapy in this case? Conservative management is the first step, basically. Prolonged drainage and antibiotic treatment. Percutaneous drainage, then ESCP with sphincterectomy and stent placement in the CBD or connection with biliary tree. Then relaparotomy can also do. And if we have bile leaks, we can introduce broad-spectrum antibiotics, basically the fourth generation, or piperacillin and tazobactam. And also in patients who have like a delayed diagnosis and are fragile, we can introduce fluconazole. So when do we refer to a center? For us, it's not important right now because we all work in a center, but in case we don't, the presence of bile peritonitis and we have an uncontrolled bile leak, and also if you have complex injuries like the Strasberg type E. And also what is important, if there's concomitant arterial injuries, this is also something the centers should treat. Here's a quick overview. I won't talk about this again. It's basically just saying if we have minor bile duct injuries, Strasberg A to D, what to do. And then in case there's it's uncontrollable, we refer to an HBB center. And if we have major bile duct injuries, we do basically the tree down the road. So what is the outcome? Basically, postoperative mortality was 1.7%, which is still a problem because of the sheer amount of these operations. And then quality of life is basically returned to an individual baseline to functional health. So let's talk about the final conclusions. First thing is patient stabilization is important, and also the timely diagnosis. We need early source control, a purposeful functional imaging. Then if we have vascular injuries, it's also necessary to diagnose these. And it's also important that we have a team, which several specialities, to treat the injury properly. For example, it's possible to treat it surgical or non-surgical. So thank you for the attention, and now we can open for the discussion.
So thank you, Vincent, for the overview of postoperative bile leaks. I think the most important to reckon is that there's still the laparoscopic or open cholecystectomy leading to a postoperative bile leak. And the type of injury is very important to classify further management. The Strasberg classification is still in place, it's used by many, although the newest would be, we didn't mention that, but would be the atom classification, which reflects the anatomic side, which the Strasberg classification does, but it reflects also the time of diagnosis, which is quite important. If you have a early recognition of bile duct injury, the first step would be an immediate repair, usually below 72 hours. But if it's going beyond, we have a kind of an inflammation process due to the bile leak, and the surgical repair is not recommended at that time. It's better to drain, wait that the inflammation goes back, and then repair in a second step. Even more important is this waiting if we have concomitant vascular injuries with, for example, occlusion or injury to the right hepatic artery. Are there any questions or any discussion points?
Yeah, Vincent, thank you very much. Very important topic, because that's something that we see relatively frequently, and patients can suffer, as you have shown, all their life for, we suppose, a very benign surgery, and they end up with much problem. When we say they do well after repair, a Dutch study has shown that's not exactly that the quality of life is poor in many of these patients from a long time. One thing that I want to challenge, you mentioned 0.4% bile leak after liver resection. I never seen this. I don't know where come these figures. Probably, I think we do not achieve that. I don't think it's in the literature. I think it's more in the 10% or more, no?
Okay, it could be that I got
okay,
the
just that to if that is go to other places that they are not coming with this idea, the figure is certainly higher. Just to come to the bile duct injury, I mean, I trained at the time when lab chole was introduced, so I was trained with these procedures. I was at the University of Toronto. We had one case a day coming with bile duct injury at that time. So we saw a lot, and the principle have remained about the same. Number one, for any surgeon, whatever title, whatever experience, if they are in trouble, they call. This is a philosophy. You have acute cholecystitis, you don't see well, you may not have experience. You call, and you don't force to see the cystic duct, you just do debulking. That you will save a lot of problems in that time. And if there is a bile leak, usually just to the cystic duct, and that's a relatively benign one too. So calling is very important. So what Dr. Oberkofler mentioned then, when you have this bile duct injury, the next question is when to operate. And it comes to the very important point is indeed referral. Everybody repeat that. Some people think it's just to get more patients. What do we see in this country and many other countries? Patients being in some places where they have some but not extensive experience in hepatobiliary surgery. They come to us after 6, 7 operations or whatever problems, etc. That is wrong. Patient in the center, that should never happen. And either in a single center where that happens, it's good to have someone else, because a lot of emotion with this. You go for a benign procedure, you end up with a disaster. I think it's always important, if you're a serious surgeon, to call other people, and sometimes even to ask someone else to handle the patient, or at least to have some help. That makes a big difference. What you did not cover here, or the Dr. Ober did, is the timing. There are different schools. There was a school at some point that you delay all the time. Put drain, you wait 6 months, you operate. That has not been our philosophy for a single reason. It has not been really a randomized trial. There is no definitive data, but the patient will suffer with drain for 6 months, etc. So we are more on our side for early operation, and we go for early almost any stage, unless there is a reason not to do so, with an abscess, an infection, etc. And the other point, I will stop here, that is never operate on this patient, and you emphasize well, without having all information. Now you give the list, depend the expertise locally. You usually start with an ERCP. We don't like too much MRCP. You cannot do anything. Sometimes it's not clear where is the leak. So I think the really right way to go is with an ERCP, when you will see where the injury is, and that may often be enough to go and proceed with surgery. If it's not clear, then you need to see from above and put some stents. You end up sometime with the Strasbourg E. You need to make several anastomosis, very complex cases, and you need here to have a perfect picture of all the duct that come from the liver, and if possible, some PTC drains, sometimes several drains. So I think this is still today a serious problem. Is underreported. I mean, I don't think we know exactly the incidence, and that's one of the reasons people try to hide that. Particularly important in North America with the legal aspect of that. There are lawyers that are specialized in just this, and attack surgeon and attack, etc. This is less prominent. It happened also here, and that hurt patients, surgery, cost, etc. But that's the way some of us in the world have to fight for this. So here, this is underreported. I don't think we know the incidence, but it still happened, and it's still today a major complication, usually from laparoscopy. Robotic probably doesn't change much, maybe a little bit less, it's not clear. But that can happen, and very often is because it's a complex case, acute cholecystitis, and the surgery or the surgeon did not have the experience to handle this. Just wanted to make this point because that's a very important topic. And Okay, good. Thank you very much.
Thank you very much as well.